think we'll start. Good morning, everyone. I'm Dr. Issa. I'm from the Mayo Clinic in Rochester, Minnesota. I'm so privileged to be here. And every year I participate in this conference, and I really applaud, all the volunteers, and it's really a vibrant society. I wish a lot of societies and foundations, follow your steps. So I have nothing to disclose. The only disclosure that I am a transplant nephrologist at the Mayo Clinic, but this does not matter. This is an outline what we will be discussing today, why you should think about kidney transplantation. We'll go over the recovery process and potential long-term implications post-kidney transplantation. We'll discuss the steps on how to manage a compromised immune system, and we'll list some potential long-term complications that can occur after kidney transplantation. So if you're afflicted with kidney disease and chronic kidney disease, I think the best option for you when you're contemplating renal replacement therapy is to consider kidney transplantation. Why is that? Because as we all know, the mortality rates on dialysis are very high. Don't want to be negative, but in this country, about 60% of people who start dialysis, they die within 5 years. You live longer with better health. It improves your quality of life. You can engage back in exercising, and you can return to work. And very important point is to start the referral process really early. And we know that when you get a kidney transplant preemptively, this is before dialysis, your outcomes are the best. As I said, if you look at this graph here, you see that we could cure a lot of cancers. And dialysis really has high mortality, even worse with some common cancers like colon cancer and breast cancer. Now, I don't want to be very negative, but those are the facts. A lot of patients who come to to dialysis or waiting for kidney transplant, they have the burden of chronic kidney disease for a long time. A lot of them are diabetic. They have underlying coronary artery disease. It doesn't apply so much to polycystic kidney disease. Polycystic kidney disease patients actually do the best. So those numbers may not apply to polycystic patients, but that's in general. Kidney transplantation indeed prolongs your lifespan, and that's taking all newcomers. If you're a 40-year-old, for example, and you start dialysis, in this country, your average lifespan is expected to be about 10.5 years. If you get kidney transplant, on the other hand, you prolong that by 25 years. So almost kidney transplantation put you back on the normal lifespan for survival. There are more benefits. As people may know, dialysis is a full-time job. So kidney transplantation give you the freedom from all the dialysis constraints, few to no restrictions in your diet in general, increased energy level. Women at childbearing age, and that's important, can get pregnant after transplant. It's really unheard of for pregnancy to be done on dialysis. More benefits. The medical complications, they all improve. We'll talk about that later on. High blood pressure improves after transplantation. The anemia improves. Bone disease improves. And there are, as I said, fewer diet restrictions. Now, in certain transplant patients, those issues may persist or actually arise after transplant, but we'll deal with those. Let's talk about the surgery. In general, the native kidneys are not typically removed. It's not actually a heavy surgery these days. The kidney is typically placed in the lower pelvic area. And surgery in general lasts about 3 to 4 hours. In the case of polycystic kidneys, we have some indications to remove the kidneys if someone has severe symptoms, chronic pain, issues, when those kidneys can become so large that they compress around them. People can have abdominal pain or flank pain. If there is no room to place an organ, a kidney, if the cysts are chronically infected, some people will have recurrent urine infections and their cysts get infected as well. Bleeding from the cyst, those can be very painful. At times, when we image the cystic kidneys, there may be actually a solid mass embedded among those cysts. The good news, the cysts, as you know, never become cancer. But sometimes when we've seen that in clinical practice, with aging, and being on dialysis, some solid mass can actually be, or some cysts that may become actually, not the polycystic kidneys, some complex cysts may arise and they can be renal cell cancer. Those needs to be removed. Most transplant centers perform bilateral nephrectomy actually after kidney transplantation. They give 6 months to a year after transplant to do that. At Mayo in Rochester, what we do actually, I think we're the only center that does that. We do laparoscopic removal. So it's minimally invasive removal of the polycystic kidneys at the time of transplant. So that's actually saves someone to have 2 surgeries. Once you get your transplant, it's typically a 3-day hospital stay. We start focusing on educating transplant recipients, mainly the medications and what to expect after transplant. Pain after surgery, the good news is brief. Initially, you may require some IV medications, but we taper it to oral medication, and within a week, most people are off any pain medications. And in general, if everything goes well, the healing process is typically very smooth. And you'll see me repeating this during this presentation, medications. We start actually teaching patients from day 0 about their medications. We print them actually with in larger fonts in the rooms. Transplant pharmacist, the transplant coordinator would come to the bedside and start the teaching. And once you get dismissed from the hospital, you have a lot of education about the medications. The dosing, typically we add 2 to 3 medications, sometimes those immunosuppressive medications. Sometimes we add more medications. So it's a little bit of complex regimen that we deal with. The schedule of those medications, when to take them, do you do your blood work before the medication, all those we start to early in the process. We start to give the teaching. Now you get dismissed to the immediate kidney transplant clinic. This is where we start the preparation to dismiss you to home. Education again, we partner with your local primary care physician. It's important to keep your own nephrologist at home. The transplant center will be also your center for life. And the best outcomes that we see when someone comply with the transplant protocols. Once you are home, of course, your immune system is very suppressed, especially early on. Just using common sense, staying away from those who are sick, taking precautions, especially with the recent pandemic in crowds and closed areas, wearing a mask, all those precautions. We ask you to check your blood pressure frequently in the first few weeks, weigh yourself every day, report any abnormal symptom, even if it's not a fever, any problem with the incision, especially if you get bilateral nephrectomy at the time of transplant, you have to be cautious and report any issue with the incision. And you'll have a frequent clinic visits, regular blood test, And typically, I tell patients, you go back to your normal life and you really feel well within a month. There are some early transplant complications, something we call delay graft function, meaning, now when we do deceased donor transplant, those kidneys travel around the country on ice or on pumps. Those may not kick in right away. If you're on dialysis and you have delay graft function, you may still do a couple of dialysis or more until the kidney actually wakes up. There are some technical issues, especially related to the wound. Rejection can happen anytime. This is why we monitor very closely, and also we monitor for infections. Let's talk about the long-term implications of kidney transplantation. The first 6 months are very, very key to the success of the kidney transplant. As you get dismissed from the immediate kidney transplant clinic, in month 1, you'll be followed very closely. You almost do blood work every week or twice a week, depending on the protocol at the transplant center or depending on your kidney function after transplant. And those will taper off over time, so you'll do less and less. But I think the first 6 months where acute rejection can happen are very, very critical to the long-term success of the kidney transplant. After your first year, you'll come back to the transplant center, depending on the transplant center, typically once a year. You see your own nephrologist. If you move far from your transplant center, you notify the transplant center. And better if you're early post-transplant to actually establish with a new transplant center close to home. It's very important. And you keep your primary care provider, and you actually, with that primary care provider, you continue doing your regular checkups. If you need a colonoscopy, you need a mammogram, whatever, those needs to be done. Now, what are the late medical complications? Acute rejection becomes less and less an issue. The good news, actually, rejection is not as frequent after transplant. With the immunosuppressive medications that we have now, it's actually at most about 10% in the first year. It goes lower and lower, the frequency of rejection after the first year, but it's always on the table. We always think about it. Chronic rejection, that's a form of your immune system responding to the foreign body that's implanted and keep rejecting the kidney over time. Most of the time, we cannot do much about it other than observing and keeping the blood levels of the medications within good range. Certain infection we have to screen for. One of them is something called BK virus. It's a virus that's can actually attack the kidneys or the kidney transplant, cause inflammation similar to rejection, and can actually destroy the kidney. This is why it's asymptomatic. It doesn't cause any fever or any. This is why your transplant center would have a protocol how to watch for the BK virus in the blood. In people who don't have polycystic kidney disease, we always look for recurrent kidney disease. Those who have glomerulonephritis, such as membranous, FSGS, kidney disease, the original kidney disease may recur on the transplant. Of course, polycystic kidney disease does not recur after transplant. And that's a question that I get asked every now and then, because a new kidney does not have the genetic defect or mutation that your original kidneys, polycystic kidneys, have. Talk about those later. So how to manage your compromised immune system? So who needs immunosuppression? Almost everyone. I said almost everyone because unless your donor is your identical twin, completely identical, you will need immunosuppressive medications. Why is that? Because, as I said, your body is always, your immune system is so robust, it keeps actually rejecting that kidney. It's actually, this is how we're created, to fight against anything that enters our body. Actually, I tell people kidney transplantation like an infection. You're bringing in a foreign body that's not yours, non-self, you implant it, and the immune system doing its job. It keeps rejecting it. So you have to take those medications that calm down your immune system from attacking the kidneys. On top of that, there are other medications that we give, some antiviral, antibiotics to prevent certain infections because your immune system is really low and those infections may become an issue. You have to take those immunosuppressive every day for the life of the kidney transplant. It's a complex regimen because we target for certain medications such as tacrolimus, we target actually levels in the blood. It can become actually a burden for someone overwhelmed by the process. So it's important to have a care partner and manage your expectations before transplant. Identify someone, a friend, family member who would help you with those. At first, you may be taking a lot of medications, but the regimen actually becomes less and less an issue and less medications over time. After the 6 months, you may be on less and less medications. And that's important even if you feel well, and that happens, unfortunately, in young people who feel invincible post-transplant. They're very healthy, they're feeling great. They stop taking their medication or start skipping medications. They forget, the evening dose, or they forget to take their medication. That's actually a recipe for rejecting the kidney and going back to dialysis. Those medications can have side effects. For example, tremors can be an issue with tacrolimus, especially with high levels in older people. Weight gain, hair loss with tacrolimus, Cellcept or mycophenolate can cause nausea, some GI symptoms. The good news, as transplant specialists, if you report any of those symptoms, we can deal with them. We have tools, we have some tricks that we do, spacing the dose, reducing the dose, targeting lower levels, changing medications because we have other immunosuppressive. So you report any unwanted symptom to your physician, to your transplant nephrologist, and some of those actually side effects may get better over time. For example, the nausea or the GI symptoms that come along with Cellcept or mycophenolate, they actually get better over time. Your responsibility as a patient is to take the medication on time, especially for tacrolimus. It's twice-a-day dosing. It has to be taken every 12 hours on time. And then we check the drug level. Typically, we do it before you take your medication in the morning. As an important thing is to know your normal values, normal creatinine after transplant. We call it the baseline creatinine after successful transplant. What's the target of your tacrolimus blood levels? Of course, coming to your appointments. And always, nurse coordinator that you are assigned to is there to help you. They're trained, seasoned nurses that will be your liaison to the transplant center. So we talked about that. You're at higher risk for infections because of the anti-rejection medication. I tell people, use your common sense. If someone is sick, avoid those sick people. Receive vaccines that are determined necessary. We'll talk about that soon. And report any unwanted symptom or any abnormal symptom. Now let's talk about some post-transplant complications. We talked about rejection. And as I said, it's not, people think, rejection happens to everyone. It doesn't. It's actually really low frequency. In certain transplant centers like ours, we do what we call protocol biopsies, meaning even if you have great creatinine of 0.8 or 0.9, we still have you do at times kidney transplant biopsy to ensure that there's no degree of rejection, even if subclinical, we call it, that actually destroying the kidney without knowing, to ensure that your kidney lasts long time. On average, kidney from a living donor should last 20 to 25 years. From a deceased donor, it varies between 5 to 15 years. Rejection does not cause any symptom. Because of the medication that we use, they're so strong. Maybe in the 60s and 70s, with early time of transplant, people would have high fever, pain over the kidney transplant. This doesn't happen these days. It's actually a rise of your creatinine. So this is why you should know your normal creatinine or baseline creatinine levels. Sometimes people who stop the medications or don't take them, they start to feel bad, like flu-like symptoms, some fevers because of the bad rejection in the kidney. So how do you monitor for rejection? As I said, the rising creatinine or any abnormal symptom that you report. As I said, those abnormal signs and symptoms only come in those who don't take their medications as prescribed. And when we suspect rejection, that's when we actually ask for kidney transplant biopsy. Let's talk now, switch some gears and talk about some common medical issues after kidney transplantation. I put weight gain on top because this is an issue, and I see it every day. I have patients who got kidney transplant. They leave, Mayo Clinic for their home. They're out of state. They come at 1 year, and I don't really recognize them from the weight gain. They could gain 30, 40, 50 pounds, Why is that? You feel well after kidney transplant. Food tastes better, we use prednisone. We use those medications can cause weight gain as well. In certain people, we use prednisone, not on everyone. So you have to be really careful after transplant. This is why we recommend a careful diet to manage your weight, because that's a recipe for post-transplant diabetes, even if you're not diabetic. Pre-transplant, high blood pressure, we talked, it gets usually better, but it can actually become an issue with weight gain. Now, high blood pressure, the good news, in most patients, we ditch most of the blood pressure medication. We have patients who come on 6 medications. They may end up on 1 or 2. Early on, with some of the medication we use, tacrolimus can cause high blood pressure, prednisone if we use it. So sometimes it may be an issue. In polycystic patients, those kidneys may be pressure kidneys. If they're large, squishing, the normal tissue of the kidneys, secreting some hormones that actually increase the blood pressure. And sometimes we have to actually do nephrectomy, bilateral nephrectomy for someone with polycystic after transplant because of very severe high blood pressure. Very rare, but it happened. And the blood pressure target follows the national guidelines of less than 130/80. New onset diabetes, unfortunately, that's an issue that we face, about 25%. I would say polycystic kidney disease may predispose to diabetes. As you know, cysts can happen in the pancreas as well. And actually, diabetes is high in frequency in polycystic patients. That's why as a polycystic patient post-transplant, you have to be careful with weight gain. How would we define the new onset post-transplant diabetes? Is the absence of diabetes before transplant, obviously. And that can increase the risk of heart disease. Diabetes can also come on the kidney transplant and shorten its lifespan, and can also increase the incidence of infection complications, such as urine infections and others. This is why, again, I say attention to weight gain. And those are some of the risk factors for post-transplant diabetes. There are things that we can modify, and there are things or risk factors that we cannot modify. So those who are at higher risk, older than 40, if you're certain ethnic background, African American or Hispanic, maybe higher risk for diabetes post-transplant. If you have strong family history of diabetes, you're more, but those we cannot modify. Things that we can modify as transplant physicians are the medications, steroid use. Now, 95% of the cases, I would say, at our center and across the country as well, across the board, we do prednisone-free protocol. And you should ask, actually, your transplant nephrologist or the center you go to if they do prednisone-free protocols, because that's actually make you less prone to diabetes. As a polycystic patient, you don't really need prednisone. Prednisone is reserved for some patients who have glomerular diseases such as lupus and other, so where we continue the prednisone after the transplant. Tacrolimus, which is the main medication that you use post-transplant, is diabetogenic. Unfortunately, it's actually toxic on the pancreas and can cause diabetes. If we see early on diabetes happening after transplant, early on, and someone is on tacrolimus, we make change to cyclosporin or other medications, and that can reverse diabetes. This is why following and keeping an eye on your blood sugars, fasting blood sugars, early post-transplant is very essential. If several months pass and we can't do much about it. So the horse are out of the barn. So that's why it is important early on to watch for hyperglycemia or high sugar. Again, weight gain and overweight can predispose to post-transplant diabetes. This is important to engage in healthy habits and a healthy diet. Now, hyperlipidemia or high cholesterol, high triglyceride, they can be an issue after transplant, especially with certain medication. For example, sirolimus, which is one of the medications we don't use as much as before. That medication can cause, actually, I've seen an LDL in the range of 400 to 500, and someone who did not have any issues with high cholesterol before the transplant. So again, steroids can increase the cholesterol and the triglyceride. This is why better if you seek a transplant center that does prednisone-free immunosuppressive regimen. Other factors that predispose to high triglyceride, of course, the diet, overweight or gaining weight. There are certain genetic predispositions that we cannot do much about it, especially for high cholesterol and hypothyroidism. What are the recommendations? We follow the general population, LDL less than 100 in general. But if someone has heart disease or coronary artery disease, we target an LDL less than 70. The triglyceride less than 150, okay? And we implement certain changes. We recommend the low-fat diet initially. In my experience, it doesn't work. This is when we pull the trigger on certain medications for the high cholesterol, such as statin, because some of those medications can cause hyperlipidemia. Now, it is important, as I said, for diabetes, also for the lipids, and certain people who have very high level of certain lipids like LDL or triglyceride, we may need to make modification in the immunosuppressive medication. And that has to be done through the transplant center, not through your general nephrologist or a general practitioner. Post-transplant anemia can be a problem early post-transplant. We give you high immunosuppressive meds. Initially, those depress the bone marrow from producing red blood cells. It's actually very frequent in the first 2 months, I would say month to 2. It becomes less and less an issue later on. A lot of people come to transplant, they're already anemic. Doesn't apply a lot to polycystic patients. Some of them are not anemic because of the cysts secrete that EPO, erythropoietin. However, it can be a common problem. The good news, it gets better. I tell people, give it a couple of months, your hemoglobin actually will get better. It's usually multifactorial, so related to iron deficiency. This is why we screen for iron deficiency early post-transplant before you go home from the clinic. After a couple of weeks from being dismissed from the hospital, we check for your iron studies. We may give you IV iron. If the kidney is still not functioning very well, not secreting EPO, the new kidney transplant, that can cause post-transplant anemia. And certain infections and meds as well, as I said, such as Cellcept and other medications. Sometimes we have to make alteration in the medications to get the anemia, to get it better. Post-transplant bone disease, as I also, said, people come with the burden of already bone disease or osteoporosis or osteopenia to the transplant. Why is that? Because on dialysis, the parathyroid is hyperactive, or when you have CKD, this is why your kidney doctor would tell you, be careful of high phosphorus foods and such. Those can actually dissolve the bone, and you already have low bone mass. You come to transplant, you get hit with steroids early on or the medications, and then you lose more bone density. The national guidelines by American Society of Transplantation is to get actually a bone density scan at the time of transplant, and then at 6 months, and then annually, if it's abnormal, if the T-score is low, signaling osteopenia or osteoporosis. The problem is coverage. Medicare sometimes does not pay for it. So a lot of insurance companies, they don't pay for it. So what we do, we actually do a little bit of tricks to trick them, saying, you have bone disease and such, to have it approved. So typically at Mayo, what we do before you go home, we do one, and then we do one at 1 year. If it's normal, we do one every 2 to 3 years, we determine. If it's actually abnormal, we implement, we tell you how much vitamin D you should take. In general, every transplant patient should be on appropriate calcium. That's about 1,200 milligram per day, and vitamin D3 about 1,000 to 2,000 units. And very important, steroid avoidance. Now it's gaining popularity. A lot of centers don't do prednisone or do prednisone-free protocols post-transplant. That's important for your bone. Vaccines, very important topic. When you come for your pre-transplant evaluation, your coordinator will sit down with you and go over all your vaccine you've taken. If you're not vaccinated against hepatitis B or certain vaccines, we tell you to do them. Why is that? Because those are live vaccines, some of them, that cannot be taken after transplant. So we make sure, actually, sometimes we inactivate people for 6 months until they finish all their vaccinations before we put them on the waiting list or transplant them if they have a living kidney donor. So that's very important. When you come to the transplant center, make sure you bring all your vaccines or whatever you've done. Otherwise, you have to do them. Some general rules: we avoid at all costs live vaccines. For example, the nasal flu vaccine, the spray, the flu, that's an attenuated virus we cannot use. The flu vaccine, the IM shot is okay and is safe. The COVID vaccine is actually safe post-transplant. It's not a live virus. So I'll give you some tips for living well with your transplant. There are tons of resources. Most transplant centers have actually assigned tons of resources, but that's what we're actually required to follow up on you. You become our patient for life. So there are coordinators out there for you. You can message them with anything. Post-transplant social worker, they help you navigate, with insurance issues, Medicare, which is better because that can be a headache. There are dietitians as well that we are required as transplant center to provide to you. Important to involve your family and friends and your caregivers early in the transplant process. And I cannot stress enough on that. Have someone help you before and after that actually, because you're overwhelmed with so much that another person or someone would help you navigate through, especially in the first few weeks. Of course, we recommend to keep yourself well hydrated after transplant. Kidney transplant like to be hydrated, taking the medications on time, do your labs on time, just general, don't smoke and limit alcohol. Important as well for those who live in southern US and such, to practice sun safety. The medications, the immunosuppressive medication increase certain skin cancer, non-melanoma skin cancer by 30-fold. It can be an issue. Applying sunscreen, wearing a hat, avoid the sun. It's very important when it's really bright. And we keep you on the schedule for your health maintenance exams. Your mammograms, your colonoscopies have to be done if they're due. Again, I'll go back, keep repeating myself, plan ahead, decide who will organize, help you organize the medications if you have someone. Post-transplant, now there are tons of apps on the smartphone to remind you taking the medications, and pill boxes, you can use them. But now with the new technologies, I don't think you need pill boxes. If you travel through different time zones, travel to Europe or other country, because some of those medications need to be taken every 12 hours. So you ask your transplant center how to change your medications. And I tell people, manage your expectations. Sometimes complication can happen. It's not your fault, but there are people who will help you go through those. When do you have to contact or come back to the transplant center? Let's say you're a couple of years after transplant. When is the time to really contact your transplant center and be your own advocate? I mean, you may see your own nephrologist. They may not be as experienced in kidney transplantation. If you see your creatinine level going up after successful transplant, even a small rise, if it's 1.1 and in 3 months you do blood work, it's actually inching up 1.4, that actually raises a flag that there may be something wrong. It could be just dehydration. You contact your transplant center, your coordinator will tell you hydrate and let's repeat your levels. If they're coming back to the normal, that's great. If not, that can signal rejection and you may need to, even if you're taking your medications on time and you have the perfect setting and perfect compliance with immunosuppressive medication, early detection of rejection goes a long way for the success and the longevity of the kidney transplant. If you're screened with a urine analysis or urine protein to creatinine ratio or whatever, albumin start to appear in the urine, you have to come back because that may signal you there is something wrong in the kidney. Rejection does not cause protein in the urine. So it could be another process. Could be rejection, some sort of chronic rejection, not acute rejection. We call it chronic antibody-mediated rejection or transplant glomerulopathy. It can be something else. Could be new disease coming on the kidney transplant. If you have any question, I get actually questions, 10 years after transplant, especially in polycystic families. Oh, my cousin got a kidney transplant, but they're not on prednisone. Why I'm on prednisone? 10 years ago, we did not do prednisone free, and it's very hard to take someone off prednisone if they started prednisone several years ago. It's actually a recipe to have rejection. I see it a lot in polycystic patients because, there are families who get transplant. My cousin did this, my brother did this. Why they're on belatacept, I'm tacrolimus. I tell them, everyone is unique. What applies to you does not apply to your family member who had a kidney transplant recently. If someone starts on new medications, there are a lot of interactions, especially with tacrolimus. You have to be careful. Check with your coordinator. My physician is starting me on this. Is that safe? If you have recurrent urine infections, okay, that's actually could be something anatomical, so you go back to the transplant center. If your blood pressure, especially in polycystic patients, is very high on 5, 6, 7 blood pressure medication, maybe that actually an indication to remove the kidneys and perform a bilateral nephrectomy post-transplant, or maybe one nephrectomy, depending how big are the kidneys. Skin cancers, they can be an issue. That's actually when you come back to the transplant center, we make changes in the immunosuppressive medications. And of course, we talked about the vaccinations. The take-home message, your responsibility as a patient is to take your medication as prescribed and on time, go to your appointment, and reach out to the transplant center. In summary, kidney transplant is a lifetime commitment, but believe me, if you're facing the choice between dialysis and different modalities of dialysis, whether home or in-center hemodialysis or peritoneal dialysis, transplant is the best. Despite all what we talked about, transplant is better. you can travel, you can do things. But it's a lifetime commitment. What I've seen in polycystic patients, they already have a lot of commitment in their life. When they come to transplant, they're ready, and they're the best patients in general. The more educated you are and your family before transplant, the better success for you and your new kidney. Knowing what to expect, like what we talked about. People think, I'm going to get a kidney transplant, everything will go away, I will not do blood work, I will not be anemic, I will not deal with high blood pressure. No. Manage your expectation is actually key. And, unfortunately, complications can happen. In medicine, we cannot control everything. And don't take it personally, but there are people who will help you navigate throughout. Thank you so much.
Thank you, Dr. Issa. Yeah, thank you, Dr. Issa. We've got about a dozen questions online. Great. And if there's time, we'll do some here from the audience. First one, what percentage of the immune system is lost when taking immunosuppressant drugs?
Well, we don't have the tools actually to measure how much of the immune system. Sometimes we use the white count. If the lymphocyte count is low, lower than 1,000, that signal, someone is very immunosuppressed. Unfortunately, there's no tool with all the advancement in medicine to check, how much of your immune system is there. There were certain tests that something called Silex was actually 10, 15 years ago, came to market, but that has proven not to be actually a good test. So there's nothing. This is why we have to take all the precautions with infections. So unfortunately, we cannot measure how much immune system is lost.
But once it's lost, does it ever change throughout the patient's life?
Yes. Over time, the immune system will get better. There is some accommodation between the body and the kidney transplant. We lower the target of the medications. So, for example, tacrolimus initially in our center, we target 8 to 10 in the first 4 weeks, thereafter 6 to 8. Some centers, even, they go lower, 4 to 6 for the tacrolimus trough level in the blood. So, and the immune system will reconstitute, and people will be less and less prone to infections as they go in life, beyond the 6 months and so. Yes, the immune system gets better.
Okay, thank you. Let's see. What about the Shingrix vaccine several years after transplant?
It is safe. Shingrix vaccine, it's not a live virus. It's actually made in the lab. So it's safe to be taken.
Okay.
Good question. We get asked that question a lot.
At 2 years post-transplant with tacrolimus, if normal weight and no diabetes, does the risk of diabetes exist anymore, or is this only the first year post-transplant?
From clinical observation, we see people who get diabetic early on tacrolimus. Thereafter, it becomes less and less. So if they're doing well on tacrolimus, I would not recommend to change it. The ones who get new onset post-transplant diabetes are the one who gets it really early post-transplant with tacrolimus. After 2 years, if they're doing well, that's good. There's no need to change tacrolimus to another medication to decrease the risk.
That's good information. All right, thanks. What treatments for osteoporosis are safe for transplant recipients?
Yeah, no, that's a good question. First of all, intake of good amount of vitamin D if you're deficient vitamin D, good amount of calcium per day. And there are newer medications, that are safe. There's new biologics that we give, like, I will not mention names because some of them are not FDA approved. You check with your transplant nephrologist, but there are newer medications now, some infusion medications, some biphosphonate that are safe post-transplant, like Fosamax and such. We use them. Most of them are safe for osteoporosis.
Okay, thank you. Is tinnitus a potential side effect of the transplant meds? What? Tinnitus?
Tinnitus. Not really, but I've seen it after transplant. We could not really pinpoint what caused it. It's not a frequent side effect of the medications or occurrence after transplant. It's probably a different process. But I've seen a couple of cases post-transplant that people have really bad tinnitus, that ringing in the ears, consistent ringing in the ears, and we could not figure it out from what to change medications over. It's not something that we see frequently. We do thousands of transplants, in this country a year, and for example, at Mayo combined, we do 1,000 transplants a year. I don't think we see that, so it's very limited cases. It's not a frequent issue.
Okay. How about GI issues? I noticed you didn't mention that, but I think it's common.
GI
right?
issues can be an issue, yeah, especially with the use of mycophenolate mofetil or CellCept. That can be an issue. Typically, it's self-limited. It can be an issue in the first few weeks, and we spread the dose over the day, or we actually do what we call an AUC for the mycophenolic acid level to see if someone is exposed to high levels. We reduce the dose. Most of the time, people get better. Sometimes they don't. We switched to another formulation called Myfortic, which is similar to CellCept or mycophenolate mofetil, but it's enterocoated. Some people say it's day and night. They get better. Some people don't. In this case, if this is really severe issue, we switch to another medication. We have older medications that we used to use, something called Imuran. Sometimes because of the really bad GI symptoms, we have to switch medications over.
Okay. Specifically, though, is there like a specific GI issue that people should be looking for?
Mostly diarrhea with the CellCept.
Okay.
Yeah.
All right, thanks. A couple questions about prednisone. I know you addressed it, but when did you say post-transplant patients should not take prednisone?
In general, with what we do now, it has been shown that prednisone-free protocols post-transplant are as good as with prednisone. So it's case by case. For example, in our center, if you're really older than 65, we may keep you on prednisone. But if you're 20-year-old or 25-year-old and you have polycystic kidney disease, you don't really need prednisone. Prednisone is reserved for certain kidney disease, such as lupus and other kidney disease that benefit from prednisone. In most centers now, I would say across the board, we don't do prednisone anymore on long term. In certain patients, we have to use it. So it's case by case.
Okay, and then and you did mention that after you've been on prednisone, though, for many years, you should not get off it, though, right?
We should not get off because if rejection happened late post-transplant with withdrawal of prednisone, that rejection may not be amenable to treatment and people may lose their kidney transplant. In very rare occasions, we've done withdrawal of prednisone if patients insist after 10 years, 5 years, but has to be done within really a lot of careful monitoring. We do sometimes biopsies and such. I typically do not recommend to stop the prednisone. We may lower the dose if they're on higher dose, but stopping it completely may be a recipe for rejecting the kidney and losing it after many years.
Okay, I think we got more questions than we have time left, but let me see here. How do you treat UTIs post-transplant? Is this regular antibiotics or something else?
That can be an issue in certain patients. One single UTI can happen, but if this is, some people have frequent UTIs. Actually, in fact, a couple of days ago, I saw a patient, she's 5 years post-transplant. She's dealing with those UTIs. We do imaging studies to make sure that none of the native kidneys harbor an infection, there is an abscess. We do make sure that there's no issues with bladder emptying. We refer those patients to a urologist. Sometimes we do cystoscopies. There may be pockets of pus inside the bladder that's feeding the infections. And in some patients, we have to use prophylactic antibiotics, meaning they go on antibiotics for life or for 6 months to prevent those urine infections. In limited patients, it can be a major issue that can actually be detrimental on the kidney transplant because the recurrent urine infections and pyelonephritis has been shown to cause kidney damage over time and loss of the kidney transplant. So it's a case by case. Sometimes we find a solution. If it's bladder emptying issues, for example, a prostate in a man that's big prostate, BPH and such, we treat it and infections go away. Sometimes we can't find the source. Sometimes people have bladder emptying issues. They have to self-cath after transplant, so that can be an issue.
Okay, I think we got time for one more question. Is there evidence that prior vaccines are no longer effective, especially if plasmapheresis is done?
Well, prior vaccine, they still hold through the transplant. Of course, the plasmapheresis, what it does is just wipe out. Plasmapheresis is similar to dialysis, but what it does is separate the blood from the red blood and the white blood, the plasma, and then remove that plasma and get replaced with plasma or albumin. So it just get rid of the immunoglobulin, the good immunoglobulin. This is why sometimes we have to give IVIG. But if someone is vaccinated and took their vaccine prior to transplant, even with the medication, they should be still okay. The plasmapheresis may cause like just transient decrease of the immune system. It should not cause issue for the long term.
Okay, thank you, doctor. Let's thank Dr. Issa again for us.
Any questions from the audience here? Or?
Yeah, if we do have extra time for the audience.
That's fine. We can do a couple of minutes, yeah.
Let's see. I saw this hand first here.
Do you recommend using genetic testing to see if the kidney is potentially being rejected like core, and how reliable do you find them?
Yeah. Well, there are so many testing now out there. We don't use them routinely at Mayo Clinic, but a lot of centers use them. It's actually what we call donor-derived cell-free DNA. They're not genetic testing, but they detect DNA of the donor in the blood of the recipient, and that can signal rejection. We use it in limited fashion at the Mayo Clinic. Other centers use it more for to keep an eye on the kidney transplant going on. So I'm neutral, and there's a lot of good data and bad data about it. But it's a case by case. We use them in limited fashion at our center.
Okay, yeah. I've been told we have time for one last question.
This is a prednisone follow-on. I understand about prednisone-free and our long-term don't want to get off because of risk of rejection.
Yes.
But this is kind of an in-between situation. A plan for no prednisone, but then BK load got up, so back on prednisone, still on prednisone, but the goal to get off. So kind of elaborate a little on this long-term. Perhaps that's going to work out for the person. Yeah, sometimes you have to reduce really drastically the immunosuppression to deal with BK nephropathy. Otherwise, we lose the kidney. So we use prednisone because it's gentler on the BK. Once you get on prednisone and you've been on it for several months, it's probably better to stay on it because that allows us to also keep the CellSapt out of the picture or lower dose of CellSapt. So yes, we have patients actually, there are patients who reject the kidney they're off prednisone, but they get rejection or they get BK issues. We have to put them on prednisone first to avoid recurrent rejections in those patients, and the other patient with BK to allow us to lower the other immunosuppressive medications so we can get rid of the BK, eradicate the BK. Okay. Okay, well, I can take your questions. We can go down. That's fine. Come on up afterwards. Sure. Thank you. Thank you so much for your attention.